only partial newborn screening. So part of Asia again, and the majority of the African countries. So as we can see, unfortunately, the newborn screening is widespread, but it's not uniform. There is a huge variability with panels for diseases ranging for 2 conditions up to more than 40 conditions. And I think one of the key messages is to see that actually showing also represented by this global map is that while actually the newborn screening can concern different countries worldwide, the scope it can vary dramatically depending on geography. And I think one message also to take home is that every newborn everywhere should have an equal chance to be identified early and treated adequately. Of course, there has been many evolutions since actually the inspiration of newborn screening by Robert Guthrie in the late 60s, the Guthrie era, where we used actually bacteriological tests and also immunological analysis. So at the moment, we have the one test, one disease model, and then the late 90s with the arrival of mass spectroscopy and new techniques, we could actually test for many diseases by using the same and only test, for example, for metabolic diseases. And till the 2010s and so present, we have advances in molecular diagnostic and next-generation sequencing techniques. They have allowed the genomic newborn screening by quantitative PCR or NGS. I would like now to present briefly the gold standard of biochemical success of newborn screening concerning one of the most diseases screened worldwide, the congenital hypothyroidism. The congenital hypothyroidism is defined by thyroid hormone deficiency at birth. It's the most frequent neonatal endocrine disorder with an estimated incidence of 1 baby to 2 to 3,000. The newborn screening for CH has been installed by a pilot study by Canadian doctor Jean Dussault in 1974, and the screening can be based on levels of TSH for primary congenital hypothyroidism, and depending on the countries, there have been some adjustments concerning also measurement of the total T34, or also thyroxine binding globulin test as in the Netherlands, where they screen also for central congenital hypo. As we know also, congenital hypo is actually one of the most common causes of irreversible cause of developmental delay when left untreated. And once again, the newborn screening alone cannot be sufficient to prevent the adverse outcome, because also the management can require timely confirmation of diagnosis, accurate interpretation of thyroid function tests, effective treatment, and of course, consistent follow-up. Thanks to newborn screening, and in countries where it is available, we can now see pictures like this with a baby with severe CH only in textbooks and not in real life. And what has brought actually the newborn screening for congenital hypothyroidism is that treated children, when diagnosed early, they can actually have the same QE scores evaluation compared to pairs, so to control children, not sick, and evaluated at different times of age, at 24 months of age, for instance, but only also at adolescence and adulthood. This is some tables showing there that we have a similar full verbal or performance intellectual quality for treated children, when actually there is a moderate and mild CH compared to not sick children. However, this is once again a world map for congenital hypothyroidism. When we're looking at national data about NBS at 2025, we can see that unfortunately only 30% of children born worldwide can be screened nowadays for CH. So I think that CH is a really gold standard example of how newborn screening has transformed outcomes, because it's a disease with high prevalence, for which it exists a reliable biomarker, TSH for primary CH, that is also a very simple and expensive test and with effective treatment available. What if we think about genomic newborn screening for congenital hypothyroidism? Unfortunately, there is a very low diagnostic rate in CH when the disease is due to thyroid developmental defects called thyroidogenesis. So the diagnostic rate varies among to 5 to 7%, and there is a very complex genetic model. However, when the thyroid is in place in situ, we have a higher diagnostic rate, estimated up to 50% of the cases. But once again, the biochemical screening by TSA, it's the best way to do the screening for these babies. I would like now go on with the genetic revolution in newborn screening, and talking to you about the example of SMA, the spinal muscular atrophy. The genetic revolution with SMA newborn screening has signified a new era in newborn screening, because we have actually transitioned from searching for metabolites and biochemical markers to detecting the absence of one gene, the deletion of one exon in the SMN1 gene, which is responsible for the disease. And we have also gone through that with simultaneous emergence of transformative gene-based therapies. Some studies also have shown that infants that have been treated in the pre-symptomatic phase identified by the newborn screening can achieve motor milestones like sitting, walking with help, that were previously impossible. So the spinal muscular atrophy is an autosomal recessive neuromuscular disease that is caused by loss of function of SMN1 gene. It is associated to a degeneration of motor neurons in the spinal cord that leads progressively to muscular weakness and atrophy. And the molecular diagnosis in majority of cases is actually what is responsible is homozygous deletion of exon 7 in SN1 gene. As you can see, where there is actually the nucleotide C here in the exon 7 is one that differentiates is actually SMN1 to SMN2. And the SMN2 is a backup gene that modulates SMA disease also severity, where actually there is this mutation and the loss of this exon. It results in low SM1 protein. As you can see here, there are different types of SMA. The most severe type is SM1 that if left untreated, it can cause death during the first year of life. And once again, you can see that the more the number of SMN2 copy numbers, the less severe the disease is. Concerning treatment, there has been emerged disease-modifying therapies worldwide. The most frequent concerns nusinersen, what is an antisense oligonucleotide targeting SMN2, and it is administered by intrathecal injections. There is also the gene therapy with a single intravenous injection, and less widely used, there is the SMNY splicing modifier or an oral solution. And I think the SMA is really the proof of concept for genomic newborn screening, and there is now, since the beginning, much more evidence about the importance of introducing this disease and saving children before symptoms be present. because firstly, some years ago, we have seen that qPCR was reliable on gut records. There was a pilot study in New York State proving that they can have up to 100% of specificity, and one nice study evaluating the treatment, actually the nursery scene in 2019, showing that the pre-symptomatic treatment can allow normal motor development if kids are screened early, and they have also more than 2 copies of SMN2. So what we have achieved so far from newborn screening of SMA, we know that it can identify up to 95% of babies born with SMA, and we have actually a better estimation of the true incidence of the disease. We had the opportunity to initiate treatment before the symptom onsets, also understand better the prognostic and predictive biomarkers for the disease, better evaluate the response to treatment, and of course, the understanding of the economic effects of the earlier treatment. The last part of my presentation concerns actually challenges and implementation hurdles, and this is going to be also the transition for Dr. Padilla, who is the next speaker. I will briefly show you this world map showing the different large-scale genomic newborn screening studies that have been launched internationally. I'm based in France, so in France we have ongoing the project Perigenomed concerning 20,000 newborns with targeted conditions. And worldwide, you can see that in US, other European projects, or even the baby screen in Australia, they have implemented genomic newborn screening in research projects. Of course, they can different ways to do it, but by targeted gene panel, by whole genome sequencing, opening a new era for the years to come, and for the babies that could benefit for that. So I think there are some challenges that we can discuss together, and I would like to mention there. First of all, this dilemma, so the variant of unknown significance, because of course, with the next generation sequencing studies, we often hang about how to interpret or actually the variants of unknown significance, and what is the relation with mild phenotypes that can be observed in some diseases. Another point concerns the ethics and the data. So what is the acceptability and the parental consent, and also the issues about long-term storage of genetic data. And the last point, I think, concerns the medical economic analysis. So we should balance the high cost, of course, of gene therapies and screening technology against the long-term savings of preventing lifelong disability. So there are some points that we could discuss all together. So before finalizing my talk, and then I would do the handover to Dr. Padilla, I would like to conclude my presentation by 4 points. Firstly, I show you that we have moved from one test, one disease approach to one sample, many possibilities model. And actually, as you have also seen, for the example of SMA, the next frontier is no longer, I think, look to one gene at one time, but looking at several genes and several diseases at once. However, there are some diseases, and I insist for that, is congenital hypothyroidism, that for which biochemical screening cannot be replaced for the newborn screening, but it can be facilitated by genetics. And I think we all, as pediatricians, should have continuous efforts to improve accuracy and, of course, decrease the false positive in already screened disease. And our mission should be actually also to expand newborn screening worldwide. Thank you for your attention. I am available for questions then, and I'm very impatient to listen to Dr. Padilla's talk. Thank you.
Thank you so much for Dr. Stupa for such a comprehensive and insightful presentation. And now we are going to the next speaker. And it is my great pleasure to introduce Dr. Carmencita Padilla. Dr. Carmencita Padilla is a professor emeritus at the University of the Philippines Manila and a global leader in genetics and newborn screening. She founded key national programs, led the passage of the Newborn Screening Act and Rare Disease Act, and developed a model screening system. An academician since 2008, she was conferred to the title of National Scientist of the Philippines in 2023. Dr. Padilla, time is yours.
Thank you. Thank you, Agustini. Um, Thank you, and it will be really good to follow Dr. Stupa, who has made an excellent introduction to the topic. So I'm going to talk about advancing genetic diagnosis, the current progress, and future directions. So for my talk, I'm going to divide it into what's happening in traditional newborn screening and then moving on to genomic newborn screening and end with challenges, just like Dr. Stupa. So as we all know, we've heard it, it is a public health program, and it really provides an opportunity for the early diagnosis and identification and treatment of infants who can be saved from the complications of these conditions. The traditional way is still the heel break, but we do still have some countries who are doing the cord blood, but our recommendation is to do the heel break. Dr. Swa started with Guthrie, but let me go back a little and to the start of why we even thought about screening. And I go to the time in 1934 with Falling, who actually identified abnormal excretion of the phenylpyruvic acid in urine, which was later renamed by Penrose as PKU, and actually took more than a decade to come up with treatment. But the important thing now is to make an early screen. And we give the credit now to Dr. Bob Guthrie, who did the research in the early 60s. And he developed a system so that you can actually test a filter card and so that we can make an early diagnosis of PKU. And that's why we actually say that Dr. Guthrie is the father of newborn screening. But moving on, it was actually Dussault from Canada who was able to show that using the same card, you can actually screen for CH. So from PKU to CH, and then eventually to McCabe, showing that we can actually extract DNA from the dried blood spots. And Millington in 1990, who developed the tandem mass spectrometry for inborn errors of metabolism. So you can see that from one condition now, because of the tandem mass spectrometry, we have moved on to so many inborn errors of metabolism, and then now we've got expanded newborn screening. I have a different map. I have a similar map actually from Dr. Stupa, but this map was updated actually in just recently in February 2026. And I just want you to look at the colors. If you look at the map, all that's blue is actually covering more than 50%. All the light blue are screening less than 50%. Everybody in green are pilot studies. And all the countries without the color are actually not doing any screening at all. But what we've seen, as we've heard from the first speaker, is that it's so diverse. You're screening anywhere from one condition to actually 30 conditions or more. And even, let's say, in China, some parts are screening for 50 disorders, and some are screening for less disorders. But what is interesting in this slide is that Africa seems to be a major challenge for all of us. As we talk about starting screening in Africa, I make a note here that in some parts of the world, we have used genomics already as a second tier in the algorithm of diagnosis in newborn screening. So let me just tell you a little about, I come from Asia, but I just want to share with you that almost 50% of the newborns are actually coming from Asia. And if you look at the five countries contributing to 71% of even in Asia, it's India, China, Pakistan, Indonesia, and Bangladesh, with varied languages, sensitivities, and varied sizes and economic development. So that means that there's so much focus that's happening in Asia right now because half of the babies are born here. So if there's one paper I'd like you to probably read, it's actually this paper by Therrell et al. It's recommended for reading because if you want to understand what your country is doing, what your neighbors are doing, what the other parts of the world are doing, this is the reference that will give you the data, and it's updated up to 2023. It's got more than the paper alone is 184 pages, and it has more than 1,000 references. So I will help you now navigate through this paper because it is the paper to read if you're interested in newborn screening. So we're doing newborn screening because it responds to SDG number 3. And if you look at if you go through the paper, there will be tables in the paper. And if you see here, in each of the table, you will see the countries now by region, whether it's a state, a province, or a territory. It will tell you the population, the births as of 2023. It will also tell you when the newborn screening started. It will tell you what the countries are screening for. If you see a whole dot, it's screening for more than 50%. If it's an open dot, it's less than 50%. And if it's a cross, that means it's just a limited basis. But just looking at the table, you can see how your country is faring as compared with your neighboring countries. And as you can see here, it covers the more common disorders. We've heard CH and SMA today, but this will also cover amino acid, fatty acid, and organic acid. I encourage you to read the footnotes because every country is different and sometimes cannot be captured in the table. So as you go through the paper, there will be a whole table just for the United States, every state. And as you can see, most of the states now have whole dots. That means they're covering more than 50%. As a matter of fact, almost 100% for the US. For Canada, it's the same. You will be able to see how the different territories, states, and provinces are actually doing. For the Asia Pacific region, you can see here so many open circles and so many limited pilot studies. So this is one place wherein we want to work on because we don't see so many whole dots in this part of the world. In Europe, a lot of them are also whole dots, but as you can see, some are screening more than the others. And you can see the diversity in the decision making on how many conditions must be tested by a particular country. In Latin America, in the Middle East, again, a mix. In Africa, and as you can see, there's very little that's happening in Africa. And when you look again at this map, it will tell you that despite the fact that newborn screening has been around since the 60s, there is a very varied implementation of the program, country by country, and even the conditions being tested. And right now, only 30% of the newborns in the world are actually undergoing newborn screening. So our topic today is looking at the future direction, but we have 70% of the world who are just starting. So what are we doing about them? So the WHO Geneva actually convened a group 2 years ago to come up with a framework for newborn screening, diagnosis and management of birth defects to be included in the public health programs of the low and middle income countries. And this was all done online. We have a couple of sessions together. We had 11 ministries of health coming, 97 participants. But the goal is, this is actually for the countries, the 70% of the world who probably have very limited and have not really started screening. So we're doing something about them. Because the next part of my talk is going to be what the others are doing now moving forward. But we have to remember that we have a major obligation to make sure that the remaining 70% of the world must be screened also. So, okay. We heard earlier, we started with PKU. Right now, we are actually screening for 30 to 60 diseases, depending on where you are actually living. But the potential is that um, down the line, because of newborn sequencing, we probably have the potential for screening for 100 to 300 to 1,000 diseases. And this is because of advances in treatment modalities, because now we have many actionable conditions, either with medical treatment, special diets, specialized proteins, organ transplant, gene therapy, and future therapies. So as we improve our ways of treatment and the potential of genomics and sequencing at the level of the newborn testing, then we will be able to pick up these children. So scientists have actually predicted a while back that newborn sequencing would one day become a routine health check at birth. So not just newborn startup screening, but newborn sequencing. And by doing the sequencing, we're actually offering the parents early guidance on care that is tailored to their child. Researchers around the globe have been independently studying the implementation of newborn sequencing, slowly moving us closer to realize this goal. And but people have been working in silos. But finally, in 2022, there was an international consortium on newborn sequencing, such that all the groups working on sequencing projects in newborns got together so that they can share their data and move forward a lot faster. So this consortium was convened in 2022 to accelerate the process by bringing all the experts together to share their knowledge, their research plans and results, making sure that we can actually get into our conclusions much faster. And as you can see, they actually meet every year. And this year, again, in October, they will be meeting in London. If you're interested to listen to all of these meetings and conversations, the videos are actually available online in their website. The nice thing about this consortium is that there is a steering committee. There is a governing body of project leaders who founded the consortium, and then to make sure that the drive is growing, driving this movement steadily towards success. And then with all the contributing partners under one umbrella, then we can concentrate all of the world's research on newborn genomics into one unified effort to improve public health for all. They continue to invite research groups, and every year there are additional participants. Now, this is the second paper that I recommend you to read. This is one of the papers of consortium. But what's nice about this paper is that the cross-sectional study actually comes on 4 stages. One is the identification of the gene list across the international newborn sequencing research studies and commercial programs. Number 2 is the compilation of the data set of the characteristics of each gene included in any program. The third will be the statistical comparison of gene lists across programs. And then fourth will be the development of machine learning model to predict gene inclusion across the newborn sequencing programs based on gene characteristics. I put here the preprint version because it is now published in Genetics and Medicine. But if you don't have access, then by all means, you can actually go to this preprint version, which is actually the same. So this is a product of the consortium, and this is another method. This is another way presenting one of the last slides of Dr. Stupa, but just to show that across the world you can see where they are. This is as of the last review, which was in 2024, and as you can see that there are 10 programs in the North America, 9 programs in Europe. There are 10 programs in Asia and isolated in other parts of the world. But what has happened is that because of this consortium, we've been able to combine the sample size of 560,000 infants. And then, as you can see, as you go through each of the studies, and I will have a slide showing you the links to these studies, the enrollment actually ranged anywhere from 48 patients to 100,000 infants, because the objective of every project is actually different. The number of genes included in the 27 programs actually range anywhere from 134 genes to more than 4,000 genes. And a total of 4,000 genes were included across one of the 27 gene list. So it's the power of putting the data together that made possible to come up with conclusions that can probably help us in the future. Now, a total of the 23 programs have published their available data, and there is so much out there for you to review. But I'd like just want to mention this highlight that the 9 newborn sequencing research programs that have published collectively have put together 68 infants by September of 2024, and they have found positive screening results, which range from 1.85% in the Baby Detect program. This includes 3,800 infants screening for 405 genes to about 9% in the Baby Sick, which is actually 159 infants screened in 4,000 genes. And of course, we had about 56% were variants of G6PD. So it's still a range, and it's a matter of, how can we have a better conclusion after we have looked at the bigger numbers. Now, this actually is the link to all the existing programs that we have. And I point out to you that it's a mix of research studies and even commercial programs have joined the program. So this is the time for everybody, anybody who's working on genomics, on newborns, to come together so that we can have better conclusions. Now, in the interest of time, I will only cite a few papers, which I personally found interesting. This is one of the first papers, actually, on sequencing as a first-year test and outcomes of newborn screening. And let me share with you the highlights. They screened about 30,000, found 29,000 in the program, and they sequenced for 128 diseases. They identified 59 more patients with the genome, with the newborn sequencing. 20 patients were affected by disorders screened by both biochemical and gene panel sequencing, and 39 patients were affected by disorders screened solely by gene panel sequencing. So this is really of course, a surprise for us that we are missing some of our patients, and there is value for the panel sequencing. Now, the next part of my talk is just showing you that of all the projects that are available right now on newborn sequencing, I will only mention 3 projects that are aiming to screen 100,000 newborns. The oldest of this is actually China Neonatal Genomes Project. They started actually in 2016. The first phase actually was from 2016 to 2021. They've just now on stage 2. But as you can see now, the goal is to screen 100,000 patients. This is interesting because this is real time. And 2 hours before this talk, I actually accessed again their database. And I can tell you that I was able to take a look at their site to see what's happening, what are they recruiting. And this is meant to end actually by the end of this year. So we expect a lot for this. Now, the 200 programs that are actually screening for 100,000 newborns are actually the US study, the Guardian study, was launched in 2022, and the Newborn Genomes Program of the UK, which is launched in 2024. So when we get this data, 100,000 newborns, probably in just 3 populations, we will be expecting more information on how we can move forward. Now, my message to everybody is that there is so much that's happening as far as newborn genome sequencing is concerned. As a pediatrician, we have to know what's going on. What I have presented to you is only a couple of papers that were published just starting January. Since it's already May, I expect that there will probably about 20 or maybe 30 papers now on different aspects of newborn sequencing. So as a pediatrician, we should be aware of what's happening with the regional sequencing, and we should be looking at what's happening also to the future. So newborn sequencing is really rapidly advancing, exploring the impacts of early diagnosis for infants. And this will support the premise that this approach will improve early detection rates for a wide range of treatable disorders. But the problem is there are challenges. So let me expand some of the challenges that were mentioned by Dr. Stupa in the first talk. Whether it's standard or genomic, because newborn screening is a whole range. You have to consider the infrastructure and the resources, and I'm talking about trained personnel to do the test and to interpret results. You have to worry about the treatments. You have to think about long-term follow-up and care, and you need to provide for genetic counseling, and that's for both standard and genomic sequencing. The second challenge will be with regards to results. Dr. Stupa mentioned this, that there are a lot of variants, and we may need to understand the variants in our own population, because the genome sequencing can lead to false positives and false negatives that will cause unnecessary anxiety. Early on, also, Dr. Stupa mentioned the ethical and legal considerations in handling the storage of genome data. And of course, at the end of the day, because of equitable access, the onset of newborn sequencing will even widen the disparity between the low and middle income countries and the high income countries because of the high cost of the procedure. We know that in time, when the price is lower, that it will be more accessible for the low and middle income countries. So what do we do now because of these challenges as a community in the world? What are our responsibilities? So looking at the future, when the cost is low, it will be a possibility for low middle income countries and LICs. And we have to prepare for the future in terms of building the infrastructure for genomics. So allow me in my last few slides now share with you what the Western Pacific region is doing as far as genomics is concerned. So recognizing that genomics is here to stay and will be moving forward, they've actually gathered experts from the different countries within the region. And we have come together actually twice, and we've come up actually with statements, a policy paper to be given to our ministries of health. And I'm just sharing one of the papers that one of the briefs that have been completed already, but we've come up with case studies from different countries to address the different problems that we will encounter once we implement genomics in our country. So building genomics capacity over in the world is actually should be done by all regions, by every country. So it's not just for the Western Pacific region, but for the rest of the world. So in summary, what I've done is to give you an update of newborn screening implementation globally through the paper by Farrell et al. It gives you a glimpse of what's happening in your country, in your neighboring countries, and the rest of the world. I've given you the landscape of genomics as it relates to newborn screening, the challenges that we have to face, and then what we should be doing as we plan for the future. With that, I'd like to thank IPA for this opportunity to participate in this webinar. Thank you.
Thank you very much, Dr. Padilla, for the excellent and insightful presentation. And now we will open the session for question and discussion. Participants are welcome to submit their question through the chat box. We have already actually one question in the Q&A box. So I will read this. Thank you, Dr. Stupa and Dr. Padilla, for your excellent presentation. I would like to ask about the challenges of interpreting variant of uncertain significance, particularly in the individual from underrepresented population in global genomic database. This is especially relevant when designing genetic panels for newborn screening that are tailored to specific population. In setting where population-specific genomic data are not yet available, would it be appropriate to design gene panels based on variant data from countries with shared ancestry or regional proximity? For example, could a country like Indonesia reasonably draw on data from other Southeast Asian population to inform panel design? Or are there important limitations to this approach that should be taken into account? Thank you. So maybe Dr. Stupa, you want to ask first, and then after that, Dr. Padilla.
Yes, thank you very much for the very excellent presentation, Dr. Padilla, and thank you very much to the participant for the question. I think it's not very easy, especially the southern eastern populations, because there is a mixity of the population, and the shared ancestry is maybe difficult to analyze. But I think what should it be appropriate, and of course you can complete my reply, Dr. Padilla. It should be maybe to, yes, we could use regional data about allele frequencies in these populations, but we should do that with a specific caution and in a very transparent way. So yes, we could use the regional databases, but and we should also prioritize the variants. I think if there is any functional or some clinical evidence for that, but not only just in the allele frequency filters. I think what is I should suggest, and also if we can update actually the gene panels with the variants, not so a very featured way, but mostly in a more continuous and dynamic way, actually to propose the gene variants. This is what I would say. So flexible design in the targeted gene panel than fix the variants list. What I would suggest, but of course you can.
I have a similar answer. You know, you can always use any the databases that are available, but you really have to look with caution, because from experience, you know, they use Caucasian populations and they don't really have your markers. And I've had so many examples wherein I have a clinical case, but I'm getting a VUS, and they cannot, because it's never been reported. So but Indonesia is actually starting already your database. I am familiar of the efforts of the Department of Health to come up with your you have a huge project right now. In the Philippines, we're also starting on our databases too. So because the only way to be able to help our population is to really come up with our own database that's really unique to our population. So you can start with whatever it's available, but it's you need something that's unique to your population. But you're fine with Indonesia. As a matter of fact, it's well funded. Malaysia also has its own genome uh, project too. We're just starting. We're just starting. So we all need to work on our populations. So in the meantime, but in traditional, of course, you know, it's easier. If you talk about the VUS and all mutations, that's different. But I think as a start, let's say for Indonesia, you really have to go beyond your traditional, beyond your number of conditions being tested, because you have to work on your expanded. You have to work on that one. So you still have a stage that you have to work on. And then at the same time, there's another group working on your genomes project. You're very lucky.
Okay, thank you so much. I think this is a very important insight for us, about the newborn screening in the future. And I have one question. If we haven't have the genomics newborn screening in our country, what is the first step for us to establish this? What do you think? For the country that we haven't have the genetic newborn screening.
I can speak from experience. The first, I mean, you can send overseas if you just have a couple of samples. It's it's a very expensive investment. So you have to, like, you know, I sent out I send out samples, okay, because sometimes they're so unique that you have to do it. You have to decide what you will set up locally. Technology is very fast, fast to change. In a couple of months or a year, the machines will be upgraded. So you have to really cautiously decide what you will set up. as far as the traditional newborn screening, you're fine. Okay. You just have to, I think that's your next step, Agustini, is how to expand your current panel. But you talk about genomics now.
Yeah.
Anyway, it's available in Indonesia. I know that for a fact. But if it's a matter of setting it up only for a number of samples, it might not be practical because it's very expensive. That is something you have to plan before you move on to spending. I'll pass it on to Dr. Stupa.
No, I totally agree. Even, in France, I don't know the birth rate and the population of Indonesia, but we have about 680,000 births per year. And we're just initiating actually genome newborn screening in a research context. Actually, screening, we have started with 2,500 newborns, and then now we will start the second phase with 20,000 newborns. But the question is not about maybe technology. I agree with Carmencita. It's about interpretation of variants, because even the first, trial of a small number of newborns, geneticists, they have encountered this problem of VUS, how to interpret what is the phenotype of the patient. So this is the key challenge for the future, I think.
Okay, thank you very much, Dr. Padilla and Dr. Stupa, for the very nice discussion. And now, because the time is up, so I would like to thank you once again to our distinguished speaker, Dr. Atanasia Stupa and Dr. Carmencita Padilla, for sharing your invaluable knowledge and inspiring perspective with us today. Your work reminds us that advancing newborn screening is not only about innovation and technology, but also about equity, access, and giving every child the best possible start in life. We also extend our appreciation to all participants for your active engagement and commitment to improving child health worldwide. With that, we bring this webinar to close. Thank you. Stay healthy, and we look forward to seeing you again in our future event. And I send to Madhumita.
Thank you, Dr. Augustini. Thank you, Dr. Carmencita Padilla and Dr. Ethnesia for the wonderful session. We would like to ask the participant to scan the QR code on the screen to fill the feedback form. As it is mandatory to obtain the participation certification, you can scan the QR code to fill the feedback form. Thank you, everybody.